So as I mentioned earlier, fundamental goal of a reconstructive surgeon is to preserve form and function and promote healing, reconstruction coverage and prevention of recurrence, which is very important. As you all know, as plastic and diabetic foot surgeons in tertiary care hospitals, every day we come across this kind of different types of complex wounds. And as we all know, it's a problem triad of neuropathy, ischemia, and deformity. And if there is an infection, that is the challenge. So, whenever we are talking about wound closure procedures, first, as a plastic surgeon, we have to look at the kind of wound we are looking at, location, depth, size. Then, of course, look at the vascularity, which is very important. If there is a PVD, if there is a varicosity. Then also look at deformities like Charcot, and whether there is an infection, superficial or deep, in which case we can't obviously go ahead with plastic surgical procedures unless we control the infection. And then, of course, host-related factors like a patient of CKD and other problems, coronary artery disease or patient having vasculitis. So all those factors we have to take into account. So first and foremost, of course, we have to establish adequate blood flow if you want to achieve success in reconstruction. And the first step in reconstruction again is a good debridement. Unless we do a proper debridement, we will not be able to have a successful skin closure. So this is the kind of aggressive debridement which is required in necrotizing fasciitis. And then of course I use various newer modalities like a hydrosurgery system, which gives us a very selective debridement. As you can see here, this was a 95-year-old lady with a PVD with a heel gangrene, underwent angioplasty, and a very nice selective debridement done with a hydrosurgery system, preserving the underlying viable tissue, wherein the negative pressure wound therapy was put and subsequently skin grafted and the leg could be saved. Or a CO2 laser, which I have been using for a long time. We have a non-contact laser, which especially can reach to the depths, and you can excise deeper tissues, especially when it is near the joint capsules or tendons. What is important, what has happened in last few decades is we came to know about the anatomy of the angiosomes, a particular vessel supplying a particular area. So nowadays, if there is a patient of PVD, we tell our intervention radiologist or a vascular surgeon, look, this is where the wound is in the region of anterior tibial territory. So try to open up the anterior tibial, because that is what is going to give us a direct blood flow coming there, and which will aid in wound healing and also help me in putting a flap. Like here, actually this patient came to me from outside with a non-healing ulcer after second toe amputation. As you can see, there was a SFA block, so we got it opened, and subsequently, of course, just a small debridement and the wound went on to heal. So again, the first thing is to correct diagnosis. So assess the extent and type of missing tissue, and then we go to what is known as a reconstructive ladder. So just starting for a simple healing by secondary intention to primary closure to NPWT to skin graft to dermal metritis, local flap, distal flap, tissue expansion and flip flaps. This is the reconstructive ladder we as a plastic surgeon use while dealing with the DFU. But there is a concept of reconstructive elevator. Now, if we are in a tertiary care center where we have adequate facilities, a team, and trained plastic surgeons who can directly go for microsurgery, we can even take a elevator and directly go for the more complex procedures. Now this is just a healing by secondary intention, where of course offloading was a must. With a standard wound care, this has gone on to heal. This is a top closure system, which is a tension relief system, especially when there is a small area, say around ankle or around a joint, where you don't want to put a major flap. You can just put this top closure system. This is a zipper-like system where you slowly keep on pulling and getting the wound edges together and heal the wound without necessitating any flap. As you can see, another example. As Lister said, skin is the best dressing. So split thickness graft, of course, is our workhorse. As you can see, I of course prefer to have a electrical dermatome and a mesher, which makes life easy. As you can see, a very nicely meshed graft there. And this was an extensive debridement which was carried out in the necrotizing fasciitis with a CRP 550, 46,000 counts. And of course, patient underwent negative pressure wound therapy or VAC therapy along with hyperbaric oxygen. And within 15 days, he was ready for skin grafting. And this is 5 weeks after skin grafting. That means within 8 weeks from the onset of his necrotizing fasciitis, patient was back on his feet. There are different kinds of skin grafts. I am just showing just to show you that plantar skin grafts do very well provided you give a proper appropriate footwear. There is no reason for us to put bulky flaps because this is a much simpler, especially in a vascularly compromised patients. Coming to bioactive dressing and tissue engineered skin substitutes. Now we have got various allografts which are available like dehydrated human amnion chorion membrane allograft. Ease of application in a non-infected wound, once a week change of dressing, and as you can see, couple of weeks the wound has gone on to heal. Or you have also areas where there is a small area of a tendon which is exposed, then you can use what is known as a human umbilical cord derived membrane allograft, which is a little thicker version, which will help in the creeping of the granulation over the exposed tendons or bone, and thereby obviating the necessity of putting a flap. Coming to tissue engineered skin substitutes, Integra was the first one to be launched in India. It is dermal degeneration template, which again obviates the need of the flap. As you can see here, a patient came from out of Mumbai, undergone great amputation after angioplasty. Looking at this, I knew there is a restenosis, so I got a repeat angioplasty done, got a good flow going there, and then did a 4-foot amputation. You can see there are exposed bones. I didn't want to shorten it further, so just put a Integra dermal template there to cover those exposed areas of bone, put a wax dressing on top, and subsequently skin grafted, and thereby maintaining the length of the stump. Another example of a lesion on the gangrenous lesion on the MTP joint. Again, patient was very keen on saving the great toe. A Versace debridement, a very clean wound bed, application of this dermal matrix, and you can see a completely healed wound and a great toe could be saved. Coming to cell-free dermal matrices, we have Dermacell and Matridum, which is available in India. Dermacell is a cellular dermal matrix which undergoes through a patented process of matricell, which renders the graft cellular but still maintains its biochemical and biomechanical properties. So this is just one example. As you can see, this can be OPD basis. Neuropathic patient, you just scoop, debride, and just clean the wound. Put 3 or 4 staples around, and as you can see the last picture there, patient has a completely healed. Otherwise, healed wounds are very challenging. Now, this is one case which was done during COVID times. So the last picture has been shared by the patient from his home. Matridum is also a cellular dermal matrix, is a collagen elastin matrix, which again is helpful in covering small areas of bones and tendons. Now, this is a very interesting case. I'll tell you, a very chronic smoker started with a small gangrenous patch on the toe. Subsequently, went on to have a toe gangrene, went to a vascular surgeon, got an angioplasty done, and got a great toe amputation done. The last 4th picture is where he came to me. The previous 3 pictures have been shared by the patient daughter to me. Looking at this, of course, I was not very happy. I knew in a chronic smoker with diabetes, they're going to be severe PVD and restenosis. Got again repeat angioplasty done and did a proximal 4-foot amputation, almost a mid-foot amputation. Not looking good at all. I thought he's a candidate for below knee amputation. The patient was absolutely reluctant to undergo higher level amputation. He said, "Doc, try to save my leg." So you have to be patient. Patient is patient. Then we started using a negative pressure wound therapy along with Recosma RBM YAG laser, which I've been using in my practice. It's a regenerative laser. I've been using it for more than 5 years now. And you can see gradually from here, second slide, he has almost come nicely to a granulating stage, but there were exposed areas of bones. Again, putting a flap in such cases, a patient microvascular flap poses a significant risk because a recipient vessel may not be good. So here, as you can see, I put that matridum on top. Subsequently, once it is integrated, put a skin graft. Then you can see a very well settled skin graft. And the last picture is when you can see that the patient is standing on his own feet with a modified footwear, and that leg could be saved. Endoform is another natural restorative bioscaffold which has got advantage. It has got a 0.3% ionic silver. So potentially infected wounds also you can use. Other matrices what I showed have to be used in uninfected wound only. Now this was one case, again PVD, had undergone angioplasty with a debridement followed by grafting over the heel, came to me with again a small tunneling wound and just packed the cavity endoform. Every week you keep on packing that, And as you can see, in about 6 weeks time, it is almost completely closed. Myriad matrix is a thicker version of endoform, multiple layers which are used specially to cover the exposed areas of bones and tendons. And this also patient was very keen on saving the fifth toe. So I did aggressive debridement. You can see the exposed joint capsule where the myriad was applied, and this has gone on to heal, and that toe could be saved. Coming to different types of flap, we have random pattern flap, we have axillary pattern flap, we have free flaps and perforator flaps. Now, local random pattern flaps, actually I'll just show you few quickly. This is like you on table decide and try to rotate and try to close the defect so that we don't have a open wound at the end of the procedure, and that will depend on the type of necrotic and viable tissue which is available to us. So another example where local flap has been used filleted from the dorsum of the great toe. Now these are the local random flaps or rotation flap for a heel defect, as you can see, which you can cover a heel defect, or a transposition flap where you can see there is a small area of exposed tibia, and I have transposed the flap and the donor site is been skin grafted, and this has gone on to heal completely. This was also another case where you can see I have put up stimulant antibiotic beads to control the infection in the bone, and in the end down you can see a very well settled flap. Transposition flap, again another example of small MTP joint ulcer following grade 2 amputation, or a VY flap, which is a VY advancement flap used to cover the defect over the plantar aspect at the first MTP joint, or a large rotation flap which is used to cover a defect on the heel, and a small skin graft put at the after the rotation, but that's on the non-weight bearing area. So this is another rotation flap which has been done. Again, a grafted area is non-weight bearing, and we have got good thick quality skin on the plantar aspect in the weight bearing area. Coming to axial flaps, this is a medial plantar artery flap which is rotated around the axis to cover the heel defect, or a reverse sural artery flap, as you can see here, necrotic calcaneum there. I have done a debridement, and that has been moved to cover the defect. And another dorsalis pedis artery based flap, again rotated to cover the tibia. And then various kinds of muscle flaps, we use intrinsic muscle flaps, like this is a abductor hallucis muscle, which is abductor hallucis brevis, which is rotated to cover the heel defect, or a abductor digiti minimi to cover the heel defect, or a free tissue transfer such as this, where after amputation of the great toe and extensive debridement, a free flap was put, muscle flap, or a free anterolateral thigh flap, as you can see here after a good debridement. Again, another case of a heel defect with a free ALT flap. So as you can see, we can start from a simple procedure and go to complex procedure depending on what kind of a wound we are dealing with, what kind of a defect we are looking at, whether what is a good whether it is a vascularity, what is the comorbidity that the patient can tolerate, extensive procedures, and then accordingly we take it forward. So I think this is how we as plastic surgeons and diabetic foot surgeons try to save the limbs. Thank you very much.